Should we start? All right. Well, welcome to another session of Virtual Global Spine Conference, everyone. It's my real honor and pleasure to have a good friend and colleague from across the ocean, Dr. Alfredo Guiroy. He's from Elite Spine Health Center in the USA and also works in Argentina as a adolescent and adult spinal deformity surgeon. So we'll be speaking about Dr. Guiroy's strategies for treating deformities today. And thanks a lot for being here.
My pleasure, Michael. Thanks for having me. We're going to go through a couple of cases, starting for the classic cases and how we address these kind of cases. And then we're going to move to some exceptions to the rule cases to discuss some strategies for addressing them. So this is a classic case. I'm going to start with a typical case and how we correct that from the concavity. This is a case example. I want to know, Michael, how you plan these kind of cases. It's a typical Lenke 1 A-N curve in a 15 years old lady. Nothing hiding. It's a classical case. Which levels do you want to instrument from what would be your UIB, lower B? How do you correct that from the concavity, from the convexity, which diameter of rod you use? I want to listen to you.
Wow, man, you're throwing it all out there. So I just did one of these a few days ago with a strikingly similar radiographic appearance. So I think the first thing to figure out is what the goal is of surgery in these kids, right? And when to pull the trigger to operate, when to brace, when to consider tethering them, and then when to submit them to a bigger surgery like an arthrodesis, like what we're going to talk about here today. So the first thing is following the Lenke rules, which is what I think most of us do, right? So the first thing I'll do is get a set of x-rays on her. Obviously, it looks like that this is already an operative curve. So anytime a patient has a curve that's at least 50 degrees before they've reached skeletal maturity, those are the patients that typically, in my opinion, are going to end up needing some type of a deformity correction, just because the literature supports that these patients are at a much higher likelihood of going on to progress their deformity into adulthood at some point. So I do like to get flexibility imaging on all of them, obviously, to establish what their Lenke classification would be. I'm curious, Alfredo, how you go about getting flexibility scans. I typically will get scans with them standing up, and I have them, side bend side to side. I think the most important thing is that when you do get scans on patients, that they're consistent, right? If you're going to get scans on patients that you braced before, you either want to get all of the scans with them braced or all of the scans with them not braced, right? So you're not kind of mixing and matching, and you're able to kind of, zero the playing field, if you will. So I'm curious, do you get flexibility scans with them standing, or do you do supine side bending over fulcrum?
I use standing bending films for these kind of classic cases. When for example, for neuromuscular cases, I do traction films. And I do it myself. I go to the X-ray room and I push the patient down, up and down with the parents typically. I don't use supine except for adult patients. I use supine and standing, both the radiographic pair for adult patient, typically for defining the distal level of fixation to see how the lumbosacral junction behaves when the patient is in supine. I typically do these bending films in the same place with the same technician that really understand what a bending is, because most lumbar bendings particularly are not well done, and they underestimate the flexibility of the curves. But once the flexibility, like for this case, it's pretty easy to understand that it's pretty lumbar flexible. It goes mostly to 0 in a reserve 4, 15 years old lady. it's pretty straightforward, the decision of moving forward with surgery. I don't do tether for mature patients. In my opinion, research 2 is the limit. I use growth potential when I do tether, and patients with research 4 have pretty limited growth potential. And we use fulcrum films mostly for kyphosis patient than for scoliosis patient. Yes.
Yeah, no, that's great. Thank you. As far as level selection here, it looks like that she bends out pretty nicely in her lumbar region. You know, she bends out from 28 degrees down to 6. So, you know, really, if you follow the Lanky rules here, the only curve that you really need to instrument would be the thoracic one. And, you know, you do have to have an upfront conversation with the patient, obviously, and the parents as well, that they're going to have some degree of a residual curve if you just do a selective thoracic fusion on them. Obviously, if they still have more growth potential, there's a you know, higher likelihood that they could go on and require adding on at some point or develop crankshaft deformity. I think pretty low risk like this. So for level selection, just looking at this quickly, I probably choose something along the lines of about, I'd say T3, probably down to L1 in a case like this. And I would just let them know you're going to have some residual curve. It's probably going to take about 6 to 9 months for that to straighten out again. If they're hell-bent on having their entire curve fixed, I think you're going to have to take her down to about L3, possibly. And I don't think there's anything wrong with that particular approach, but I'd probably stop at L1 in a case like this myself. As far as, you know, rod diameter, usually use 6L cobalt chrome in the concavity. I typically use 5.5 cobalt chrome in the convexity, put in the, you know, the concave rod first. And I typically will use polyaxial screws at the top and bottom. And then I usually use uniplanars on the concavity. And then typically polys on a convexity. And I'm typically able to get a pretty reasonable correction.
Well, I completely agree. We're on the same page. I think there was one question pending about the brace. When I'm testing the utility of a brace, I use films with a brace in position. When I'm assessing flexibility of the curve, I take out the brace, and when I see progression of the curves, I take out the brace. I only do X-rays with the brace when I'm assessing how effective is the brace to correct the deformity. But I typically don't do more than 1 or 2 X-rays with a brace in the typical case of an AIS. Well, as you mentioned, I do the same. I use polyaxials in the top and in the bottom. I use uniplanars in my apex. I draw this only in the concavity. For this kind of cases, the concavity is the key. The convexity helps, but most of the correction, if not all of the correction, is done from the concavity. For these cases, I use the touch vertebra concept Linky described a couple of years ago for Linky 1 and Linky 2. As you can see again in the pictures, this is a touch vertebra. Previously, he described the substantial touch or the just touch vertebra. Now he used the touch vertebra. If the vertical line touch the vertebra in the lumbar spine, you can choose that as a distal level for your fixation. We do asymmetrical bending of the rods. We over-rod the concave and under-bend the convex rod. The idea of that is to take the spine up from the concave side and to push the spine down with the convex side, as you will see in the video in a couple minutes. First, we lock the superior and the inferior screws, and then we try to push the spine up to the rod. For flexible cases, I use 5.5 rod, typical chrome called 5.5. For more rigid or more severe deformities, I use 6.0 rod, from cobalt 2. The idea of doing different bending of the rod is to push the convex down to convex side down and to elevate the concave side up. There's different kind of maneuvers or techniques for derotation. We're gonna go through in a couple of minutes. This is a short
Alfredo,
video of
can I
this.
ask you a quick question? Sorry to interrupt you.
Sure, yeah. Go.
Actually, this slide works fine. About your distal level selection. Can you just repeat that for the audience? How you go about using that lanky rule to find your LIV?
Absolutely, yeah. We use the touch vertebra concept. Lenky described a couple of years ago. He described the first vertebra in that is not included in the structural curve that is touched by this line. You can see here the first vertebra in the lumbar curve that is touched by this line is L1. And this applies for Lenky 1 and Lenky 2 curves. Once you have the touch vertebra, it's in this case is L1. You have if you use that level as a distal fixation level, you have a very low incidence of revision surgery for your distal level, and a very low risk of adenoma. That was published in GBJS like 10 years ago. He still used it. Lenky still used that rule, so we apply that, and so far so well. We're using the same concept. So that's how we choose the distal level for Lenky 1 and Lenky 2.
Great. Before you get into the video, I think it's also worth getting into some of the granular details for the audience too, as far as how you actually place screws. So before we get to the correction techniques, obviously these are arguably some of the more challenging screws to place, right? Especially in the concavity, they're hypoplastic, they're really sclerotic. You're dealing with a lot of type D pedicles. You can use fluoro, navigation, freehand. I think both of us are freehand predominant. So what's your technique for safe pedicle screw placement, especially in the concavity?
Well, the step-by-step of putting a freehand screw is I first take out the inferior facet with an osteotome. I do 2 cuts from inferior to superior and from lateral to medial. So the superior articular process of the level I'm gonna instrument, it's completely visible. I take out the cartilage of that joint, and I see the intersection of the superior articular process and the TP. I know the pedicle is, it depends on the level, but it's pretty close to there. So I put I start my hole with a drill. I do a small hole, and then I go with a finder. This is a pretty difficult skill to explain. No? It's acquired with time and a lot of screws, but you gotta go very perpendicular to the line, to the shape of the superior articular process. If you go perpendicular to that, it's pretty typical that you're going good in the coronal plane. And if you're going straight to the floor, it's probably a pretty straightforward screw. For a kyphotic patient, you need to see if you're in the low thoracic or in the upper thoracic. We change the sagittal direction of the screw. But for a typical orthotic case, it's pretty straightforward. The screw is perpendicular to the floor. That for sure depends on the level. It's not the same screw at T2. It's pretty got a lot of convergency. That T12 that is pretty straightforward. But my technique is take out the inferior articular process first. Identify the junction between the TP and the superior articular process, and then starting doing the hole. Once I do 2 centimeters with my Lenky pedicle finder, I palpate. All the surroundings are good, are safe. I stimulate with a pedicle stimulator for my neurophysiologies. I'm good, and I change the direction of my Lenky, and I go to the desired length, 35, 40, or whatever. And I do again a stimulation, a pedicle stimulation. I'm good. I'm going with a definite screw. That would
As
my
far as the
step by
size of
step.
screws, as far as the size of screws that you use, is there a typical width diameter? I mean, I'm typically not
Yeah,
using any less than a 5.5. Most of them usually range from 5.5 35s down to 5.5 45s, depending on the length. But I don't like to use
yeah,
anything less than a 5.5. Are you using
yeah.
4.5s or do you
I
go up to 6.5s?
no typically I go to up to T9 with 6.5 and upper with 5.5. That's a typical case. That well depends on the weight of the patient and the age. It's not the same 9 years old guy that in 15. But for a typical AIS case, it's T9 up to, with 6.5 and up to T2 with 5.5.
And then
For
how about your
T1 and T2, I typically use 5.
right? And how about your screw density? Do you have any views on that? I mean, typically, I think most of us
Yeah,
try to fill up the concavity with high density screws. Are you leaving
yeah.
some out in the convexity routinely, or are you not?
Yeah, I try to put all my screws, particularly for my very severe cases. I try to put more screws. If I skip one level or two, it's not a problem. If I can find a pedicle, it's a pretty difficult. The palpation is not a pretty safe one. I try to skip that level. It's not a big problem, except for the lower levels. I need to at least 3 levels below and above in the top and in the bottom. But I'm not very crazy about I have to put all my screws. If I have a good day, a sweet day, I try to put all my screws. But if some screw is difficult, I skip it. It's not a big problem.
Right. And do you do posterior column osteotomies just in a concavity, or kind of what's your view as to how many levels you should be doing PCOs at? And are you even doing complete PCOs? I know there's some deformity surgeons that will just do inferior facetectomies at every level, or does it really depend on the curve magnitude for you?
Well, it depends on the curve magnitude. For my typical case, 60, 70 curve angle curve, I just do inferior facetectomies. I take out with my Ronju the midline. I release up to the flavum. And I go in multi-level doing the same thing. For my screw insertion, I take out the inferior facet. So I'm doing the release just with that. For curves over 70 or 75, I go for a complete Ponti, at least in 3 or 4 levels on the apex. For double 70 curves, I do both apex, doing 3 or 4 levels. But that depends on the flexibility and the magnitude of the curve. If I see that the curve is pretty flexible when I'm going in and doing fair facetectomies, and I push from the convexity and it looks pretty flexible, I just do that. I try to avoid complete facetectomies. It takes time, it takes blood, it increase complication. I try to straight with the less osteotomy I can. We're good?
Yeah, I'll let you proceed. Sorry about all those questions. I just want to make sure we hit some of these granular details, because when I was in my training, you see all these big cases, people do with great outcomes, but it's really nice to kind of go into the details as to how you do it.
Absolutely. This is the typical case. We do middle incision. We do bilateral simultaneous approach. That saves a lot of time. Once we have the approach, we start with a freehand pedicle screw placement. We typically go bilateral simultaneously. That saves a lot of time. And you can see from the other side that the trajectory of the screws is follows a logic, and you're going as convex, and the other side is going contralateral. So once we have all the screws inserted, or at least all the screws we wanna put, you can see here we're going bilateral simultaneously. So this is a pre-medial and the other lateral. We had the screws in. We do the posterior column release. This case, just take out the midline. We do an asymmetrical rod bending. We start with the concave rod. We lock the superior and inferior screws. and we have the screws locked. We try to push the spine up to the rod to address some of the hump. Then most surgeons thinks this is a derotation maneuver. This is not derotation maneuver. You're just translation from the coronal plane to the sagittal plane. You're not derotating anything. Actually, the screws need to be derotated in the contralateral position. So this is not derotation. This is translation to the sagittal plane. Typically, this helps a lot with the coronal curve, but won't change anything the axial plane. Some inside bending if the correction is not perfect. And then we put the system, we do derotation. In the concave side, we use uniplanar screws. That helps a lot with the derotation. This is an en-bloc derotation. You can do it in block or segmental. That's not much different in the outcome. As you can see here, I try to push a little bit more than that looks all right, because the spine have memory. So if you're pushing a lot, when you release the rotation, the spine will move again to the original position. This is the final position. Then we put the convex rod. We use some cantilever maneuver and try to push the hump down in case there's an important hump. And after that, we'll do the decortication. This is an important step of the procedure. If the patient doesn't fuse, will be a problem in the future. So you don't need to avoid that. You need to be very considerate about that. And this is the final correction in the sagittal and in the coronal plane. And this same strategy applies to different time of Linky 1. This is Linky 1C. As you can see, for this curve, the sagittal vertical line doesn't touch the lumbar curve. So this is Linky 1C, 62, typical case, AIS, 15 or 16 years old lady. When for some Linky 1C, we do selective fusions. In this particular case, there's a lot of shift trunk, as you can see in the clinical picture. We decided to go for both curves, and using the same strategy of going from the convex side, doing the translation, and then the derotation. You can address both curves because the only structural curve was the thoracic curve. It's the same as the Linky 1, but the distal level is different. So using the same step by step, you can correct these kind of curves.
So do you think that doing a selective thoracic fusion on the Linky 1C puts them at significantly higher risk of adding on in the future if you don't?
Yeah, well, that depends. That depends on, there's some factors you need to consider in a Linky 1C to go for selective fusion versus double curve fusion. If you have a big trunk shift to one side or the other, more than 2 centimeters of trunk shift, that's not a very good idea to do a selective fusion. If you have there's a ratio about the number of lumbar vertebrae included and the angle of the cup. If that ratio is big, it's a bad idea to do all the selective fusion. And we do a lot of selective fusion for Linky 1C. And the other factor is when the Linky 1C is go to the right, Linky 1 or Linky 1C right. That's a very bad idea, as Firoz Mijanji described that. When the Linky 1 is going to the right, it's not a good idea to do selective fusion, and it will be better to include the lumbar fusion, the lumbar curve.
Great. There's a question in the chat box.
Yeah.
Adnan is asking, in bigger curves, do you typically lock the proximal and distal screws as well? So
no, that's a good question. For bigger curves, it's pretty difficult to do that. and we typically start from the top. We lock the top, and then we try to push the spine to the rod. And once we have the rod in position, we lock the lower screws. This is possible locking the upper, the top, and the bottom screws is possible in small curves where the rod is pre-aligned. It's pretty easy to do. But for bigger curves, we start from the top and then we lock the bottom. That's a good question.
When you're derotating, how tight are you keeping your screws in the areas that you're derotating? Obviously, those are pretty loose, but the screws at the top and bottom, you're keeping relatively tight, correct?
Yeah. Well, that depends on how rotated are the top and the bottom. If you have a pretty neutral vertebra, for example, L1 or L2, and it's pretty neutral, you can see both verticals in the AP. You can lock L1, and that would be very good. If they have some rotation, and you're gonna address that, you have to leave the screws with some loosening to go with the general apex rotation that will go with the derotation itself. But if you have a pretty neutral lower instrumented vertebra and upper instrumented vertebra, you can lock it, and that's good.
And then when you derotate, are you always just derotating with one rod in? Typically, when I do it, I'll usually have two rods in, but I noticed that you only do it with one rod.
Yeah, for small curves like this one, it can be used with only one rod. My boss, John Ashgard, do it with both rods in. He called this the airplane maneuver. He always said that the airplanes depart and arrive with both wings at the same time. So it seems reasonable to try to correct the deformity from both sides at the same time. But I found pretty difficult to translate with both rods. I typically don't have the same amount of correction. It's maybe my bias, but it can be done with both. And there are lots of paper comparing one technique versus the other with pretty similar outcomes. You do both too?
I do, yeah, but I'm willing to do it like this though to see if I could get better derotation.
So and this is the same strategy we use for all curves that have a pretty significant thoracic curve, and the lumbar curve is pretty neutral. Like in this patient with severe neuromuscular scoliosis, we put the screws, we put the crown, the concavity rod, we do the releases, and the correction is pretty good. For this kind of cases, we don't look for derotation. There's a neuromuscular. Our objectives are a good sitting posture in the wheelchair. So we use polyaxial screws all across the spine. It's pretty easier to put the rods in.
Can I just ask you a quick question? May not be related
sure.
to neuromuscular, but if you're dealing with the case, I suppose it could be a relatively small magnitude, but some of these larger magnitude cases, if you get neuromonitoring changes, how you deal with it, at what part of the case would you typically see it? For instance, let's say you're doing your posterior column osteotomies, and then you drop out your MEPs on the concave side. How are you dealing with that?
Well, there's an algorithm for losing potentials, and there's that depends on the stage of the surgery. If you lose potentials when you put in the traction in, and the patient is still it's not in the prone position, you got to you take out the traction. If you have typically you have to look at the 10 minutes before. It's before the osteotomies, it's before traction, it's before screw placement. If you have a screw when you have a doubt about some screw, we're gonna take out the screw. If you having the loss of potential when you're doing the derotation, you got to lose the derotation. I mean, it depends on the stage of the surgery, but there's an algorithm in the wall of my OR for my anesthesiologists, for my neurophysiologists, for the surgeons, and everyone knows what to do when we lost potentials. First, see that it's not a false positive. There's no anesthetic problems, there's no hypotension, there's a lot of things that can change potentials, but it's a real loss of potentials. You need to address step-by-step traction. If you have traction, bad screw positioning, derotation maneuver, you gotta reverse that.
There's a couple questions in the chat box about how patients fare after this type of an operation. I can tell you in my experience that the adolescents fare significantly better than the adults do. If you're doing an adult scoliosis case, those patients are generally in the hospital for several days, and there's a lot more pain limiting factors that withhold their discharge in a timely fashion. With adolescents, they're usually out of the hospital in, I would say, probably about 2 to 4 days. Do you have a similar experience, Alfredo?
Absolutely, yeah. And these neuromuscular scoliosis are the worst. I mean, AIS are pretty winners. They're every single case go well. Got 1 day in the PITS ICU, and then if the pain's under control, they go to the regular bed and for 2 or 3 days, and they go home. Neuromuscular scoliosis stays in the ICU for longer days. They typically have respiratory problems, or tracheostomies, or feeding problems, or gastrostomes. So they have a lot of problems, and it takes longer, have a very high rate of complications, like 40% of complications in neuromuscular scoliosis. And for adult patients, they take at least a week. That's a conversation I have with my patients. If you have a big surgery from upper thoracic to the pelvis in an adult patient, they're gonna be in hospital for a week at least. So, what about strategies for kyphosis? Well, when we have classic kyphosis, Scheuermann kyphosis, like in this lady, she's in her 40s, 80 degrees curve, it's pretty straightforward kyphosis. We typically put polyaxial screws from the middle up and reduction screws from the middle down. And that's why, because we try to address the correction with multi-level pointy osteotomies, and then lock the rod in this position. We lock the polyaxial screws, and then the rod in the very outside the skin, as you can see in this video. And when we push the rods down bilateral simultaneously, we're doing this cantilever maneuver. We're closing the osteotomies, and we're doing the reaction of the kyphosis at the same time. So reduction screws in the lower part of the construction that makes this reduction much easier than when we're using classic case screws. And this is the pre and the post-op images of this patient.
What's your strategy to prevent distal junctional failure in your Scheuermann's population?
Yeah, well, PJKs and DJKs are the main problems for this Scheuermann kyphosis. I think the right selection of levels, it's very important for these kind of cases. This lady had a previous about the lower spine for this lady, have a degenerative disc disease in L5S1. But typically I use these kind of cases go typically from T2 to L2. This is a classic Scheuermann kyphosis reduction or fusion. In this case, I went to L3 because if you can see the vertical line, it goes pretty well for L2 in this case, but I only can insert 1 screw in L2. I have problems doing the screwing the control outside. I broke the pedicle, so I decided to go 1 level below the plan that was L2 in this case. But it typically goes from L2 to T2 to L2.
You ever run
for
into
most
issues
cases, right?
where you've do you ever run into any problems where you've overcorrected these patients and take
Yeah,
out much of their thoracic kyphosis? And if that does
absolutely,
happen,
yes.
what's your bailout strategy?
Absolutely, yes. That's the main problem of Scheuermann kyphosis is it's difficult to see in the intraoperative how much you're correcting. And that typically pretty flexible. So when you're doing a lot of punches, it goes pretty straightforward and reducts a lot. And my goal for this kind of cases is 30% of the kyphosis corrected. No more than that. If you have more than 50% of the kyphosis corrected, the DJK rates go and PJK rates go higher. If you have issues in the junctional problem, you need to see the previous correction. In some kind of cases, we have to lose or return to the previous kyphosis and leave the correction alone. For example, if I have from 80 to 5 to 50, and I try to keep it in 60. I overcorrected this case. It got worse. It got worse. It takes this patient have like 5 years to follow up. When I see the X-ray, I see, oh, I corrected too much. My goal in this case will be 60, no 50.
And how do you deal with these patients if they develop a bit of a pitched forward neck posture? I've seen a few patients in my practice that have been sent to me from other providers in the community that maybe have had Scheuermann's kyphosis corrected, and then they come back years later and they just kind of have this, this pitch forward neck posture because they've kind of compensated in such a way that they've lost their cervical lordosis after you've corrected.
Well, that responds to many problems. If you overcorrect this, the brain is set for a position in this position, and you change that position in 2 hours. So the brain will try to return to the previous position, the 30 years position. Most of the kyphosis I saw in this kind of patients were a very bad soft tissue injury in the upper level. So they approach to T1 and they instrumented to T3, and they destroy the facets and destroy the interspinal ligaments and destroy the attachment of the muscles. So the patient have no compensation for hyperextension. So they lost the potential, but was a iatrogenic loss of potential. Once you have a chin and chest in revision of these cases, it's pretty difficult to correct. I mean, typically you need to go up to C2, and it's not a rule. It's not easy way. Once you start, you need to go forward.
Right. So
you can use cantilever maneuver for other type of kyphosis. Like this one is a congenital kyphosis in a 5 years old lady. And once we have done the BCR and have all corrected, we start using cantilever maneuver for doing the correction. As you can see, it's bilateral, pushing down, and then we use this rod reducers to help putting the rod into the screw. And the power of this maneuver is pretty high. It's John Asgard pushing down, and his arms is like my leg. So it's a lot of power in a 5 years old kid. And you have the risk of losing the screws. So you have to know that it's pretty sensitive maneuver up to when I push down and I'm not losing my screws. But it's a pretty powerful maneuver, as you can see in the intra-op X-rays with a overhang with degrees kyphosis with a pretty nice correction.
Are you? Yeah, that's Alfredo. That's a beautiful correction. Are you placing any type of a strut in your vertebrectomy defect in a case like this?
Typically, no. We have published that with John 2 or 3 years ago. I remember the title of the paper is "Do you need a BCR for all congenital kyphosis?" That's the same question, and We have done BCRs for all of these cases, but typically, once you correct the kyphosis, there's a very limited space to put a cage there in a 5 years old kid. It's you can put a T-leaf there, but not the typical mesh or expandable mesh. It's pretty limited space.
Yeah,
so,
that's what I mean, like a small T-lift cage, like a little bullet cage or something, just to act as a fulcrum.
If there's some gap after the BCR, John used T-leaf cages actually for those gaps. But in this kind of cases, there's no gap, there's bone on bone, it's not needed. But that depends on the gap. Yeah. We have so about how to correct from the concavity. There are just some exceptions to the rule and when not to correct from the concavity to avoid problems. And the typical cases are when you have a high left shoulder and when you have kyphosis and scoliosis. Those cases are better approached from a convex side. This is a case of a man in his 20s with a high left shoulder, a typical Linky 2 case. You can see clinically and in the X-ray that the left shoulder is higher. And the problem with this kind of cases, and this is not a difficult curve to correct, but when you open the concavity of the core, the left shoulder will be higher than before surgery. So, and that's pretty bad for this kind of cases. It's pretty awful to see. So there's no problems in the sagittal. So for this kind of case, this is Linky 2 with a high left shoulder. I think it's better to treat these cases going a little bit higher to T2 because of the risk shoulder imbalance in the post-op. And how we try to address or prevent these kind of problems, we put a screws, and in this typical case, we put a short rod in the left from T2 to T4. We do compression of that rod in order to put the left shoulder down. And then we do the correction from the convex side with the rod in the left side in compression. Once we do all the translation and do the correction of the curve, we take out the short rod and put the regular rod in the concave side in order to avoid a worse deformity in the post-op.
Yeah, that's a good tip. Those don't come along all that frequently, with the left shoulder.
Those rare cases, yeah.
Yeah. It brings up another good point is what are your red flags that you see on preoperative x-rays that might trigger you to get an MRI scan in a patient that has scoliosis?
Abnormal findings in the physical examination, like hyperreflexia or loss of cutaneous muscular reflexes, skin patterns like myelomeningocele or whatever hidden deformities, high left shoulder, left thoracic curve. In those cases, I order an MRI. I typically order MRI in all the cases I go for surgery, but in these cases, I do it for sure. I think it's mandatory to do an MRI. And that's interesting because I have patients with a pretty straightforward scoliosis, girls, 15 years old, typical right thoracic curve, normal physical examination. And when I do an MRI routinely, I find Sarangomarelia or Chiari or whatever, and that makes put us in trouble, That maybe we missed don't do the pre-op MRI.
Are you ever addressing those congenital anomalies first, or does it depend on whether or not they have any growth potential remaining?
That depends. If I see a typical pattern of the curve, for example, as I said, left thoracic curve, pretty angular shape, and I found a Chiari or other malformations or a tumor or a syringomyelia, I typically address what I think that was a driver of that deformity first, and then I do the deformity. But I found a lot of Chiari malformations, type 1 Chiari, 5 millimeters, and with a classic AIS, and neurological findings was completely normal. I do the deformity first without a problem. There's some increase in the risk, but it's pretty insignificant. Other strategy we use a lot for the severe deformities is traction. We can use traction in the pre-op or in the intra-op. Halo gravity traction in the pre-op is extremely useful for severe deformities, childs. We start with 20% of the weight, and we're going gradually increasing that weight up to 10% a week, and to a maximum of 30% or 50% of the weight. You need to be in a hospital when you can see the patient daily, and sometimes 2 or 3 times a day. You need to address for cranial nerves, typical the exterior cranial nerve, hand pain, and how are the pain status, if they're loose or they get infected. But they typically go the patient story is pretty good. We typically use 4 pins. Some particular conditions like skeletal dysplasia or neurofibromatosis, we use more than 4. We use traction intraoperative in a lot of severe cases, and I think it's a very, very helpful maneuver. Once you're doing the releases and the facetectomies, when the patient is in traction, you're using the natural forces to straight the spine a little bit more, and that change a 90 degrees curve into a 70-degree curve in the intra-op, and it's a completely different deformity. Well, typically use Gardner wells in the skull, and we use traction. I like to use bony traction by femoral traction, but in some cases, like in this neuromuscular scoliosis, when a lack of pelvic obliquity, you can use asymmetrical traction. You can use traction in one femur and not in the other. So we're trying to push in the hip and the pelvis in this case, in the right side down. We put first the cranial halo, and then we put the pin. This is a Kirchner pin in the femur. It's pretty easy to put for any orthopedic resident. You can use the resident for this. And it's an extremely powerful maneuver for traction. This is a very small guy, like lower than 20 grades, 20 kilos, and you can put up to 5 kilos in the leg, pretty tolerant with the femur. As you can see, after we put in this patient in traction, how the deformity opens just with the traction. We have done any release there, and when we see this in the intra-op, we're using, in this case, just traction in one leg. You can see the deformity when we open and we do the approach. And once we're doing the releases, you can see the deformity, how it straightens pretty easily with just the traction and some release without the need of 3-column osteotomies or nothing more powerful. And we also use that for correcting the pelvic obliquity. That's pretty useful for a better sitting in the wheelchair. We plan different for severe deformities, how we use or how we put which screws we choose for these kind of patients. For classical cases, as we mentioned, we use polyaxial in the top and in the bottom. I use uniplanar in the apex of the curve. For these severe curves, I try to use some reduction screws because the screws are pretty far from the rod. And if the curve is not pretty flexible, it's pretty difficult to put the rod in. So you started to bend rod to the spine, and the correction it's worse than expected. Like in this case, severe kyphosis scoliosis, and we got a pretty good correction with using that strategy. For these severe deformities, we lost in some way the potential of doing derotation. We plan to correct both sagittal and coronal plane, but we lost the potential of having derotation. So if we have a big hump, we tend to do the thoracoplasties for these kind of cases. We discussed previously with that with the patient. But it is what it is. It's difficult to get to address the three planes in these severe cases.
So Alfredo, that's a beautiful correction. That's a very, very challenging case. You had mentioned that you use reduction heads, certain deformities like this. What happens if you don't have a reduction screw and you're having a very difficult time getting your, your reduction tower because the gap between the concavity of your tulip head and where the sagittal profile of your rod is just is not marrying up. So what are your kind of pearls to get that link back up again?
First, when better the release, it's easier to put the rod in if you have a very good release. But in some cases, you have done a beautiful release, a big osteotomies, all the apex is done and it's still stiff. You can put a short rod in the concavity and a different rod from the top and the bottom. I have done sometimes that, and for severe over 120 degrees curves, it's impossible to marry the rod with those screws. The curve is pretty difficult to address. So we put a short screw, a short rod in the concavity, and a different rod from the top and the bottom, and I think address the problem of stability and go into fusion. It doesn't look that good in the X-ray, but it is what it is. It's sometimes you need to do that. So for double curves, is mostly the same strategy as the concavity correction technique. Like in this case, a Linky 3 curve, pretty flexible. This is not a problem, but you can do a different strategy for derotation. You can do en bloc derotation for both curves. Typically in my set, I don't have two systems for doing derotation for two curves. I have only one set. So for these cases, you can do segmental derotation. That means in this case, for example, we put neutral L1, we lock L1, and once we keeping that stiff, we try to derotate T12 and then T11 and then and going up, having one level pretty neutral, using that as a reference for a derotation of the other levels. We typically do the en bloc derotation, but a lot of studies have compared that with pretty similar outcomes. Steve Wang from Shriners have a paper published comparing both techniques with pretty similar outcomes. In some cases, we have these kind of curves, double curve, a Linky 6. The main curve is the lumbar curve. The strategy is pretty similar. I know in this kind of cases, my priority is this lumbar curve. It's a bigger curve. It's an 18 years old lady. It's more stiff than the typical cases. In this kind of cases, I do the translation of the rod, but I have the rod in place, using a lot of rod reducer at the same time. And once I have the translation of the spine to the coronal plane, if I'm not happy with the coronal plane, I do compression distraction in the concavity and the convexity to have all the screws level. If I have all my screws level, I know that the rotation is good. If I have one screw upper than the other, I need to do some compression distraction for level that up. And this is a final correction, and this is
well, in these double curves, Alfredo, which in double curves, which rod are you putting in first? Because obviously in the lanky 6, the lumbar curve is going to be of higher magnitude. So are you putting in the right-sided rod? I can't tell.
I put the concave rod on the lumbar curve.
Okay,
I typically correct from the concave side of the major curve. In this case is a lanky 6. The major curve is a lumbar curve. So I put this rod. This is the right rod first. And
then how do you manage lordosis? Because typically when you're doing scoliosis corrections, the majority of these obviously are the majority of these are thoracic curves that we're treating, right? The double major curves are a lot less common. So how are you managing to ensure that you're putting the proper amount of lordosis into it? Because typically we're rotating the rod into sagittal kyphosis to pull them out of axial rotation. This is a little bit different conceptually.
Well, I try to never do distraction in the lumbar spine. I do compression in the convex side, but I never do distraction in the concave side. Distraction in the lumbar curve is a kyphosing maneuver, so I try to avoid that. I try to bend the rod with some lordosis in the lower part, as you can see in this rod. I take a picture in the lateral position and I measure my lordosis for these lumbar curves. It's typically not a big problem because I rarely go to L4. I typically go to L3. And the spine is pretty straightforward to L3. It's some minimal lordosis, but the lordosis is from 3 to the sacrum. But that's a very good question, and it's not easy to address that if you want to have a very good coronal correction. You're losing some of the lordosis. So to end with this session, ASD is completely different animal, adult spinal deformities. Typically, we need to include the lower spine to the pelvis. So for this kind of cases, we try to correct from the bottom up. It's completely the opposite of the AIS case. We try to use a neutral vertebra to start correcting to the bottom. You need to assess both sagittal and coronal plane. That's completely difficult, and it's pretty different from AIS. You need to be very careful with obey 2 cases. We're gonna discuss that in a minute. We don't do the rotation. The bone density is completely different. We're going to address sagittal and coronal plane. We don't care about the axial plane. This is a case, looks like a pretty straightforward deformity, but this is a pretty difficult deformity to treat. If you look at the lumbar-sacral junction, you have the lumbar-sacral junction pointing to the convexity of the main curve. And that's a very stiff lumbar-sacral junction. If you don't address this lumbar-sacral junction and put L4 pretty parallel to the floor, when you open this curve will open pretty easily. You're gonna have the patient this way. And when you see the full spine X-ray, when I saw that, that was my face. Right, doesn't look good at all, right? And I put a nail leaf in this patient, but I didn't correct L4-5, and that's I learned a lot from that case. You need to see pretty good at these cases. When the patient is to the concavity of the curve, it's pretty easy to correct. You could correct the concavity and the patient will be very straight. When the patient is decompensating to the convexity of the curve, be very careful about those cases. For a typical case of an adult deformity, we try to correct from the bottom up. So typically the only level vertebra is the sacrum of the pelvis. So I start to correct my deformity from there, from the bottom up. I put my screws in the pelvis, I put my screws in the sacrum, and I see in my line that the rod needs to be in this position. So I try to get the spine to the rod and not the rod to the spine, to follow like a train line, you know. Following that line, it's better, and you won't lose the sagittal or the coronal plane. So as take-home messages, classification helps a lot. When you're in doubt, ask a colleague. We ask for advice for most of our cases. Traction is extremely helpful for severe cases. Use it. Pre-op planning is 80% of the success. To know what to do, what to use, how to do it, and when not to do it, and when not to do surgery. And as Mark Twain said, good judgment is a result of experience, and experience is a result of bad judgment. So time and doing this will give you valuable experience.
Alfredo, that was absolutely fantastic. I learned a lot. I'm sure the audience learned a lot. That was a real tour de force on both adult and adolescent spinal deformity. A lot of very positive comments in the chat box. So thanks again for being with us. This is going to be a fantastic lecture to have archived on YouTube. I'm sure I'm going to reference this many, many times before cases to brush up on some adolescent deformity concepts. So thanks again, Alfredo. Next week, I'm not sure what we have. I know Wendy Gibbs is up to host someone. So we're looking forward to seeing everybody next week. Thanks again, Alfredo. Appreciate it.
Thank you, man.